I want to welcome everyone to this session of Endeavors, which is the Department Colloquium for African American Studies here at Yale University. I'm Jacqueline Goldsby, I'm chair of the department, and on behalf of our faculty, our graduate students, our undergraduate students and staff, I want to welcome everyone here. It's exciting to see faces and names that I don't recognize, and that's exactly the kind of outreach we want to accomplish with this series. I want to say a couple things about the series itself, what it is, what's on deck for us this semester, the remainder of the semester, and a couple of reminders about Zoom etiquette, how we're going to be running this particular session. I'll start that now by saying, as you all are now, probably your mics are muted, and we'd ask you to keep your mics muted throughout the discussion today. It's okay, as some of you are doing, to keep your videos turned off. Zoom fatigue is real. The important thing is to be engaged with your mind and your thinking, and which leads to the third Zoom etiquette point, that we will be using the chat very actively during this session. That will be the conduit, and our other host today, Professor Crystal Feimster, will explain this in a little bit more detail, but I just want to say now that we'll be using the chat function to talk with one another. You can post ideas, thoughts, questions, reflections. If you want to pose a question directly to our speaker today, you would send that question or query, that comment, to Professor Feimster through the chat. But those are some of the ground rules for our discussion today. But again, Endeavors is the Department Colloquium for African American Studies. And for those of you who are with us for the first time, there are two hallmarks to our colloquium. First of all, we all gather together because instead of separating out our colloquium according to subfields, we understand our work in Black studies to be interdisciplinary. So we deliberately have one forum where we bring together leading critics, scholars, artists, activists to present work in progress, work that they are doing right now, so that when they come together and think with us, we can help them sharpen their ideas, their practice, the projects that they're engaged in. And we in turn can bring their methods, their questions, their energy to the work we're doing in our own respective fields. So two hallmarks about this colloquium: it's about work happening now, and it's in progress, and it's about interdisciplinarity. This semester, the theme of our colloquium, typically we allow ourselves to kind of range across the field of Black studies and to invite who's ever doing the most exciting work that we want to think with. But given the exigencies that we face right now, the ways in which we are reckoning, right, this is the term, with all of the ways in which race has made and unmade the modern world and the particular fates of Black people within it, we are deciding to focus our attention on what it means to be Black now, and to think about and to hold conversations towards the change, the revolution that needs to happen in so many different areas of life, of one of which will take place in 2 weeks on November 3rd with the election. And so we've organized a whole series of conversations to think about those pressing areas where scholarship and action come together. For those of you who were with us last month, we started off with Natasha Brown, who's a voting rights activist, and her work with Black Voters Matters, which is absolutely pivotal for the moment we're in. And the ways in which she actually offered us a new theory of thinking about electoral participation and doing that work. She was literally holding her conversation with us on a bus, traveling through North Carolina, going to another voter registration event. It was absolutely scintillating. And we'll soon have that discussion posted online for you to listen to and think with. Today, we're going to be focusing on the politics of mass incarceration and health justice with our guest, the physician activist, Dr. Emily Wang, who Professor Feimster will introduce in just a moment. And I just want to call attention to the fact that we have 3 more events lined up for the rest of the semester. You can register for these events on our department's website. These events will be held on November 9th, November 19th, and December 10th, where we will be continuing these discussions around, for instance, the role of art as protest, how art pleads freedom, with the painter, activist Titus Kaphar, and with the poet lawyer, I want to say laureate, but he's a lawyer, Reginald Dwayne Betts. We will have 2 sessions on the politics of policing with our new colleague, social psychologist Philip Atiba Goff, through his work for the Center for Policing Equity. That will be on November 19th. And then on December 10th, another of our new colleagues, Elizabeth Hinton, who's a historian, and one of our longtime allies in the law school, Tracy Mears, will be talking about the work that's happening at the Yale Law School's Justice Collaboratory. So I invite everybody who's here today to sign up for those events. You can go to our department website and register for those Zoom links. I want to take a couple more minutes here to thank the collaboratory, so to speak, that's organized and running this series. Our principal co-sponsor is the Center for the Study of Race, Indigeneity, and Transnational Migration. And its director, Stephen Pitty, Professor Stephen Pitty, and the assistant director, Matthew Tanico, have been absolutely indispensable in helping us to organize and to mount this series. And I really want to thank them for their collaboration and their support. I want to thank the African American Studies Department Senior Administrative Assistant Vanessa Epps, who's done a tremendous job working with Professor Crystal Feimster, getting the word out, getting the series organized. Thank you so much, Vanessa. I also want to thank our tech support, Emmanuel Bissell. I hope I'm pronouncing your name correctly, Emmanuel. He's keeping this room up and going. So thank you so much, Emmanuel. And finally, I want to thank our chief curator of this series, Professor Crystal Feimster. Now, I can let it go without saying how amazing and brilliant and wonderful Professor Feimster is, because many of us here have the opportunity and the honor of working with her every day, taking classes with her maybe 3 times a week. But we have the chance to work with her every day. But for those of you who don't know her, I just want to make clear that Professor Feimster is one of the nation's leading historians of the US South and of Black feminist history. Her award-winning book, Southern Horrors, transformed how we understand post-Reconstruction era racial violence by excavating the underknown histories of rape as a tool of racial domination, along with lynching in those decisive eras. And she's increasing the magnifying power of that analysis in her next books. She's writing 2 of them that examine the uses of sexual violence in the US Civil War. These are going to be game-changing books, and we're very lucky to have her bringing that intellectual power to organizing this series. So I want to thank her for her work. And with that, I'll turn it over to her to introduce our guest today.
Thank you, Jackie, Professor Goldsby, for that lovely introduction. And also thank you for, making sure that endeavors continued this term under all of the stress and circumstances that we're all facing. You were the one who said, we've got to have these conversations. And we in the department and those in the Yale community were more than willing to say yes to these conversations, and for all of us to kind of do this work and be in this space together in these difficult times is really important. So thank you for insisting on that and leading us in having these conversations. I also want to thank Vanessa. I just want to add to your note of gratitude that Vanessa has sort of come in new to AFAM and really rallied and supported me in this series. So thank you, Vanessa, and Emmanuel as well. Nothing but gratitude for making this happen. It wouldn't be happening without the 2 of you. So thank you. I also want to thank in advance my racial formation folks, just because I'm putting you on the spot. I know you're here This is part of like your first year induction into African American studies, and we're glad you're here. We want to see you here. We want to hear your voice, and I'm hoping that you're going to help me amplify some of the things that Professor Wang is going to share with us. So when you hear her saying something that you think needs to be repeated or needs to be highlighted, I want you to hit that up in the chat. And I will repeat some of the things that she says, and I'll ask questions and have her go back over some things for us, because this is a moment for us to really learn from Dr. Wang. And so, you know, let's make sure that we highlight what's important here. On that note, what's important is what Professor Wang is going to offer up to us today, and I want to get that conversation going. And first, I want to introduce Professor Wang, or Dr. Wang. So I have to say, I actually have been sort of, I don't want to say stalking, but following Dr. Wang for a while now, on both the professional and the personal front. Full disclosure, she lives in my neighborhood, and she's got 3 daughters who are the same age as my youngest, Thea, and they were in Thea's kindergarten class. So I was like, who's this person who's got triplets? How is she doing this? And then when I found out that who she was, I was like, oh my God, she's amazing. And I also sort of first came across you through your efforts to ban the box, your work around that. And it was one of those issues that I had never thought of. And I remember when you sent me an email about it, I was just like, who is this person? What is this issue? And so I have kind of tracked you and followed you, and I'm so excited that I get to introduce you to this community, both as like an amazing community person in my neighborhood, but also as an amazing scholar. So Dr. Wang is an associate professor in the Yale School of Medicine and directs the new Center for Health and Justice called SEICHE. I think I got it right, but she will correct me if I didn't, I'm sure of it. The Center for Health and Justice is a collaborative between Yale School of Medicine and Yale Law School, working to stimulate community transformation by identifying the legal policy and practice levers that can improve the health of individuals and communities impacted by mass incarceration. She also heads the Health Justice Lab that does, which is a research program which receives National Institutes of Health funding to investigate how incarceration influences chronic health conditions, including cardiovascular disease, cancer, and opioid use disorder, and uses a participatory approach to studying interventions which mitigate the impact of incarceration. And I want to just sort of hit that again, that she uses a participatory approach. And I think for those of you who are coming out of my civil rights course, I think this is something I want you to kind of pay attention to. And I want you to think about some of the people that we've been talking about, Ella Baker and participatory democracy, and see what Professor Wang is going to tell us about that. And finally, she's an internist, and she has cared for thousands of individuals with a history of incarceration, and is the co-founder of the Transitions Clinic Network, a consortium of 40 community health centers nationwide dedicated to caring for individuals recently released from correctional facilities by employing community health workers with histories of incarceration. And I'm going to leave it there. There's a lot more I could say. It is on our flyer, and she does have an amazing website that you can go to that links to many of her articles that she's published on a range of topics. And hopefully we'll get to cover some of them, but I know that we're not going to be able to cover everything that she has her hands in. But do check out her website and the articles that she's published. And on that note, I'm going to turn it over to Emily to really introduce us to herself and her work and what the new center is going to be doing and how it builds on the work that she's already been doing. So welcome, Emily, and thank you.
Thank you. You know, it's just a deep honor to be here. I have to say, it's one of these things when you're looking through your calendar, and I really, am like probably minute to minute now, but at times week to week, I just was so excited to be here. It's always joyful to be in conversation with Crystal, and in particular, for something entitled Conversations for the Revolution, sign me up. And so, you know, I think one of the things that I'll start with today is that, you know, I think it's critical. There's not a lot of physicians, like there's not a lot of spaces within the schools of medicine where physicians are talking about the revolution. And yet, I think it's critical to have physicians and health systems really actively engaged in this. And, you know, in my world, what this is increasingly, especially with young students, younger students, residents, kind of more junior faculty, is talking about the abolition of the police state, elaboration of the carceral state. And the reality that I present, which is that those are all yes and true. But I've had the opportunity as a practicing physician, as Crystal has indicated, that, you know, if you look at examples right now of closing Rikers, you know, and if you talk to physicians that are practicing within Rikers, you know, and they've had historic drops in the jail population that we could go into now. So historic, just with, you know, stupid, idiot, easy changes that should have long happened but haven't, and then they finally did. You can get the population down from 13,000 to 11,000 to now, you know, it's 5,000. But at the very end of the days, there's probably about 1,000 people that won't be able to go home. There's no place to go home. There's no health system to care for them. There's no place for them to live. Our communities have entirely abrogated their responsibilities at the community health systems, the housing systems, et cetera, to those individuals. And so in thinking about kind of dismantling a carceral state and thinking about kind of what abolition looks like, it requires a real deep reconstruction, a real reckoning with the social structures that do exist. What does our social contract look like? It's so fractured now that we can't actually provide for that space, that we can't talk about kind of issues of revolution and abolition without saying that then you need an all hands on deck approach. And folks like me within the health system have to be on board. And so it's in that space that I sit, and I'm often kind of in tension, which is the practicality that every Friday, Steph knows this, I see patients that have just come home from prison and jail. And so that keeps it real, because there's a real reality, an individual with their family sometimes, and then certainly returning into the community where the resources are just limited. And it's that space that you can think really and truly about what revolution looks like. It's going to be a process. It's a long haul process, and it needs and requires a interdisciplinary intersector approach to really thinking about how this looks. So I'll start then by saying this, that increasingly in my work, and Professor Goldsby alluded to this, what I love most is being in interdisciplinary spaces. We recently have a grant now actually that will be looking at COVID-19, and I'll touch on this a little bit, within prisons and jails. And have an amazing opportunity also to look at the history of mass incarceration and pandemics. And so Elizabeth Hinton will be partnering on this. We're going to look into legal barriers. And again, that's Tracy Mears partnering on this. To me, this is where it lies, is that if we do not have scholars and also people that have been incarcerated and also people that are currently incarcerated knee deep in the solutions of the past, knee deep in what has worked in the past and what just didn't get scaled up, and knee deep on what we are presented with now, we're just not going to get anywhere. And so it's that place too that I really like to be. All right, so what I thought is, usually that this is Zoom land and it's kind of terrible for me, but usually what I usually do is to say, you know, like, try to answer the first question is like, why the hell is a doctor kind of interested in this stuff? And for me, the place that's easiest for me to share with you are just photos of prisons and jails and what health systems look like, just to give you a picture. So I'll do a raise your hand if you've, and I'll just try to quickly flash over my Zoom, if you've stepped foot into a prison or jail before. Okay, so good number, and then people aren't on Zoom, got it. And then what about, have you been in healthcare settings? Okay, all right, Crystal and Amy, super. So, so this will be somewhat new to some of you and then very new to others of you. And so if there's terms, and unfortunately, once I share my screen, I can't see the chat, but maybe I'll ask Crystal to stop me if you feel like I'm throwing out jargon, Crystal.
Okay, I will.
One of the places I'll start is just to share that, oftentimes people have, and I think the media presents it poorly, which is that the folks who are incarcerated, that's 2.2 million individuals, and then we have a whole system of community supervision, but 2.2 million individuals that are incarcerated are this like young, healthy lot that's able to exercise. They're doing well, they did a crime, they're inside. And the truth is that that just isn't the case. So, the patient demographic, and I frequently use the term patients. They're not all patients, but that is just my lens, so I apologize for that. But the patient demographic is changing. The population behind bars, given the incredibly long sentences we've had, have meant that there's a disproportionate proportion of individuals that are 55 and older. And when the last estimates were looked at, it's about 80% of individuals within jails and prisons that have a chronic health condition that warrants longitudinal primary care. So this includes like this patient here, he's got COPD. I shared these pictures just for you to give a look at what healthcare looks like. They're waiting to see a doctor. So there's one patient here that's getting kind of an albuterol, like a treatment to help open his lungs, next to another patient who has a mental illness and he's in a cage. So this is how healthcare is structured behind bars. And so when I say that about 80% have a chronic health condition, so for a range of what I mean is a range of conditions. So, high blood pressure, asthma, COPD, like this guy has, to also hepatitis C, infectious diseases like HIV and hepatitis C, to also depression, post-traumatic stress disorder, schizophrenia, opioid use disorder. All those conditions require, I'd say most physicians would say a primary care doctor. And so while, we have the impressions that folks are generally healthy, in fact, they aren't. And they're aging behind bars in systems that were never designed to actually provide the healthcare for chronic health conditions.
Emily.
Yeah.
I'm curious, I'm thinking about a few years ago, there were Black women in Alabama, two sisters, I think, who had like kidney failure. I don't remember if you remember this story, but it seems to me that there was a moment, and I don't know if it's still the case, that around sort of decarceration that was linked to the economics of healthcare, right? That in some of these states, the Republicans and more conservative people were willing to kind of think about decarceration and reducing the number of people who were incarcerated because of health expenses and the sort of cost of healthcare. Is that something that has happened or is happening?
Yeah, that's a really important point. So yes, it is. That, I've been doing this for over a decade, and I'd say right now we're at a place of increasing bipartisan support that kind of, whatever you call this, the carceral state, mass incarceration has been a failed policy. It hasn't changed violent crime rates and also costs us too much. So you'll see more right-leaning folks or just blatantly right folks, saying, there's a whole right on crime, right? That it's the costs of incarceration that are what are driving, is their animus for trying to decarcerate our country. But there is consensus that the prison and jail population is too big. And in large part, these costs are driven by healthcare costs, exactly as you're pointing out. The aging, your two sisters with end-stage renal disease, they cost. And they cost more in corrections than they would in the community.
Right. Okay. Thank you.
And then, of course, and especially thinking about COVID, which we could talk about a little bit, because maybe that's my work in progress right now that we can touch on, that prison environments can, of course, exacerbate poor health. And I just want you to think about the world in which we're living right now, right? We're masked, socially distanced, and think about these individuals right here. So all these pictures, I should say, come from California Department of Corrections. I actually did my residency training in San Francisco and had a longitudinal primary care clinic within this prison in San Quentin. And so, these pictures come from them. And, I just use it to highlight that it's incredibly overcrowded. Again, our policies of mass incarceration have led to situations like this, where people are triple bunking in gymnasiums. And then, of course, in these circumstances, are hotbeds for COVID-19. We can go into that for forever, but you can only imagine how. You just can't socially distance in places like this. But also places where, because of the stress, rates of cardiovascular disease, we're hypothesizing, are increasing. So, there's a lot of work thinking about kind of toxic stress and what this looks like, and amped up stress responses. And in particular, what that means for short-term health, but also long-term health, what that means for mental health, but also physical health. And so the actual environments, the built environment, but also the ways that prisons and jails are defined really kind of can magnify different conditions in health. And so what drew me to this is as follows. So this blew my mind. Like, I don't think I would have ever been, I was a primary care doctor thinking about medicine, and I wouldn't have seen, if you asked me 20 years ago, would this be kind of the focus of what I did? It wouldn't have been. But prior to the Affordable Care Act, prisons and jails are one of the only places in the US where healthcare is constitutionally guaranteed. And so what this meant for me, it kind of is inconceivable, but you'll see why this matters a lot. There was a court case in 1976, Estelle v. Gamble, that kind of created the constitutional rights to healthcare behind bars, is that if you think about a population, this 2.2 million people that are incarcerated, who are disproportionately Black, Latino, and a racial and ethnic background of low income, oftentimes prisons and jails are the first place where individuals access healthcare as adults. This is where they learn, this is where they experience, this is where they meet their first doctor, this is where they understand their chronic conditions. And so this has significant bearing for their kind of relationship with the healthcare system, their trust of the system. You can imagine now in COVID-19, their trust in kind of participating in any sort of issue that is tied to kind of healthcare system design. And to me, it also speaks to this, which is that it has been a place, as you'll hear me go through, a place where people are first accessing preventive health measures, actually do get treated for the first time for hepatitis C in certain circumstances. And so it's a conflicted place, partially, I think, because we do such a terrible job in the community, and because we house so many Black and brown people inside, that there is this perverse kind of experience of healthcare that starts in prisons and jails and then gets transitioned home. So if you look at our data now, there's about 40% of individuals that are incarcerated are newly diagnosed with a chronic condition while they're incarcerated.
And Emily, so, since so many young Black and brown folks are having for the first time interacting with doctors, I'm curious if you could speak to who are the doctors? What kind of doctors are doing this kind of service? Like who are the doctors?
I actually think, Crystal, it's like a mixed bag. So in the news, you're going to hear it's like the problematic stories, right? So people that are not boarded in their specialty, oftentimes it's like, misbehaving physicians or criminal physicians, frankly, that have lost licensure, then moved to a different state, then have started a practice within a correctional system and doing stuff out of licensure. And also, I would say that there are also physicians that commit to it because they're kind of interested in taking care of patients that are more vulnerable, really trying to think about this as, and I'd say it's the younger generation of physicians that are more embracing of kind of a more social justice vision, but it's a mixed bag. I also think you're going to a place where, if you think about community health systems, there is an infrastructure that protects you. So you, Crystal, when you go to the hospital and you're seeing a doctor at Yale New Haven Hospital, you can rest assured that there are certain kind of approvals that have to be taken on in order for that hospital to get financed. These are national guidelines of a certain quality of care that has to be delivered in the health system. Otherwise, they don't get the funding from Medicaid, Medicare, and private insurers. Okay, so you can be certain of it. There is no federal or state mandatory oversight of healthcare behind bars, period. None. And so again, there's a heterogeneity. So I don't want to impugn, colleagues of mine that work inside doing the good work. And also You just don't know what the work is, right? It's like we have no way of knowing. So when you go into Yale New Haven Hospital, you can rest assured that it's been approved by JCAHO. When you go in here, there's just no way of knowing. And this is inherently the issue, which is that there's no transparency. There's no kind of, our taxpayer cash pays for the care that's delivered in Connecticut Department of Corrections, and you have no idea of knowing if they're meeting the standard metrics for quality, nor do you know about the quality of physicians.
Right. Okay, thank you.
And so, I just highlight this, and maybe this photo is better for kind of physicians in training or health, students and the health allied professionals. But, again, while there is this constitutional access to care, it's just totally, entirely different. And so this was a patient that I had met. He had just been diagnosed with a condition where your blood pressure is out of control. It's so crazy that you might be at risk for stroke. It's called hypertensive emergency. So he's sent out to the outside hospital, so that we have to contract out, of course, because most prisons don't have their own hospital, comes back in, and this is supposed to be the place where he recuperates. Okay. So, just to start, just look around. I'm rounding as a physician, and everyone in earshot, correctional officers there, the person right next to him, incarcerated as well, is listening. You throw the cuff through. Many of you probably have gone to a doctor where they check a blood pressure. This is not properly positioned. He has to place it on himself, and you're kind of having a DL conversation with him, trying to see, what did you learn? If you're the doctor in there, and I was, of course, there's drugs in there, and you want to kind of talk to him about things that doctors would talk about, and you're not able to. The other thing to just note is that, this patient will never have to call a pharmacy to get his meds, never even have to give himself a reminder. The whole kind of how he manages his chronic condition, for those of you who are on blood pressure pills, what happens is that every morning he's called at the crack of dawn, correctional officer wakes him up, he goes and makes a line, his cup is filled, it's a med line, he has to, drink it, and then a nurse checks to see if he's cheeked it, and then and then he makes it back to his room. And so it's incredibly passive. It's totally paternalistic, it's childlike, but adherence is 100%, right? If you don't adhere, we've done studies that have shown this. For instance, let's say you're I'm not feeling like getting an insulin injection today, right? For whatever reason, folks, participants have stated in studies that they've been sent to solitary confinement. And so there is this entirely different notion of how healthcare is delivered, how it's administered, how people see it, and how people are punished for it within corrections that, of course, doesn't translate into the types of, doctor-patient relationship you want to create. The other thing too is that every time this patient wants to see a doctor, so in Connecticut, for instance, for a chronic disease visit, you have to pay $3. So you're like, well, what's $3, right? Well, $3 is equivalent to 4 days work if you're lucky enough to have a job. And so again, there's just so many different barriers that exist for people that are incarcerated to actually access care. This picture I highlight, so it's just pointing out this pink slip. And so it's a kite that patients have to fill out again when they want to see a provider, a healthcare provider, a doctor. And so, again, this is no longer happening in California, but it's still happening all over the country. The person fills it out, that then gets evaluated by a correctional officer. The correctional officer then decides whether or not it's a valid medical concern. It goes to a nurse, and then it goes to a physician. And so again, all sorts of barriers to getting care. This also is an HIV clinic. And so again, there's just no confidentiality. Again, there's a correctional officer walking by. Everyone in this line knows that they're all going to see the HIV doctor. And so just the whole notion, the kind of values that we hold true and are principled, and ones around human dignity and rights are infringed upon largely a population that is of low income and racial minorities that, again, have rarely accessed the community health system. And then, I always show this picture, and, for me, this is just the deep brutality, the kind of the violence that the health system can exert on individuals. And so, think about that first patient that I showed you, an older gentleman that, maybe is requiring oxygen now. And this happened to be not the same guy, but another patient who needs chronic oxygen administration for his COPD. And you can just note here that the oxygen's outside his solitary confinement door. And so, you would hear him when it kinked, like bamming on the door. And you'd walk by and doctors would walk by. And I remember being a person in training being like, how's this permissible? And it's because the values of kind of safety, really trump the values of dignity, but of health, right? And so there's many, many different expressions of violence that are kind of just ingrained within the system and are difficult to, of course, shake off when people come home. You wonder why there's all sorts of notions within medicine about non-compliance and people that are mistrustful, and these people. And then you think about this, and that's life-preserving. To actually be mistrustful. It's life-preserving to not kind of trust in health systems. It literally is the smartest and strategic thing that you can do. And so, where my work kind of sits mostly is at this intersection, I'd say, is that the vast majority, Jeremy Travis said that, like 95% of individuals come home to the community, and that's about right. That, for what it is, we have 2.2 million in, and 95% of folks will actually end up coming home. And so I think what is the most interesting to me is that it's actually their health outcomes. If you compare what happens when they're incarcerated versus when they come home, are significantly worse when people come home. So you have about a 12 times increased risk of dying in the first 2 weeks post-release. Big seminal study published in, New England Journal of Medicine that showed that the most common cause of dying is overdose, but then heart disease, homicide, homicide, suicide, and cancer, and then other chronic conditions as well, depending on what state's data you're looking at, like hepatitis C cancers from that. But again, a really elevated risk of dying in those first 2 weeks post-release, a really elevated risk of hospitalizations, and not surprisingly, a worsening of all chronic conditions. And this is because we have just so many barriers to people coming home, right? So inabilities to, as Crystal mentioned, you can't find a job because you always have to check a box. You cannot find a place to live. There's a ban on food stamps. You cannot, find a place to live because you have a criminal record and you can't live in public housing, or your family member can't house you because you have a criminal record, and it just goes on and on. And so the real challenge for us as a health system is figuring out how better to engage people who come home. And so one of the things that Crystal alludes to, and I won't go into it much now, but it's just that we, using participatory approaches about now 15 years ago, started a transitions clinic program in San Francisco. It's where I trained, and really deeply in partnership with people that had been previously incarcerated. There's a long civil rights movement that is embedded there that we partnered with All of Us or None, and really created a program that I think was centered around the values, preferences, and needs of people with histories of incarceration. And core among that, and here's the picture here on the right, who's our first community health worker, have community health workers that are embedded within primary care clinics that have histories of incarceration themselves. And really, I think part of what I've found in doing this work, I personally haven't been incarcerated, but when we started this program, I'll say, and now we have like 45 programs across the country, there's so many deep naysayers. Like our whole science, our whole notions, especially within health systems, is one about mitigating risks. Like all this stuff is wrong in these people, and we just have to make them more normal, right? So that there isn't a lot of value. And what we're really trying to do as a community, within transitions, is to change that narrative. There's so much going right. There are lots of people and assets within communities that have been impacted by mass incarceration, and that too should inform our science. And so, through the years, what we've been able to do is, using kind of the best of empiric design, using randomized control trials, show that transitions clinic programs actually does improve healthcare utilization, improves primary care. It actually reduces future criminal justice contact. And so really trying to shift the entire narrative, which is that there is value in also looking at what functions well in these communities and also then studying that to scale. The second thing I'd say is that, I'm just moving through these pictures a little bit more, is that in seeing these patients over time, one of the things I've realized is there's just not a lot that's known about this population. The science is terrible. And I share with you this figure from a paper that we wrote. I won't orient, how are we doing on time? I see, not good, Crystal.
We're doing great on time. I mean, I think a lot of this information is really important. So I want you to share it with us, and we go to 4:30.
Okay.
So there will be
you'll like tamp me down. I just share with you this because I do think it's something that's lost on. It's something I guess I've come to see over time. So, I'll have patients that'll ask me like, well, what do you think, doc, is the best choice for me? Like, what do the studies show? And so I share with you this study that we did. So on the left-hand column, I mean, you guys probably don't recognize it, but these are large cohort studies. So population-based studies where they followed thousands, sometimes tens of thousands of individuals in the US that are really keyed on, they're funded by the NIH, the National Institutes of Health, so taxpayer dollars, trying to figure out the core etiology of heart disease. Okay, so these are all the big ones like Cardia, Jackson Heart Study, MESA, Enrich. I mean, you see them all there, okay? And so we took all the studies that followed people for over 2 years, okay? And we're intentionally designed to study what are black-white differences, okay? And what we wanted to do was, in particular, to see how much mass incarceration has impacted the validity of these studies. Okay, so we know that, based on earlier work, there's about a 1 in 3 lifetime risk of a Black man being incarcerated in this country over his lifetime. Okay, and it's even higher, the risk is higher in certain communities, but it's 1 in 3 population-based over in this country. And so one of the questions we wanted to know was, how often do these big population studies actually go into prisons and jails? How often do they include the folks that are incarcerated? And then let's say that you recruit someone in the community, a young, healthy Black man, and then he gets picked up by the system. Do they actually follow him in? And the problem with that is the follow-up is really important for these studies, because if you don't have follow-up, then you don't have internal validity. You just can't make any conclusions about Black men as a subcategory in these studies, okay? And so what we found first was these are the 25 biggest studies that NHLBI funds. How many of them, Crystal, do you think looked at incarcerated individuals? I'm putting you on the spot now.
No, you can. Let's say 10% of them, maybe, get them?
All right, 0, none, not a 1, okay? One of them, Cardia, asks one question. It's been following people for 30 years. I mean, all the stuff that we know about heart disease in young folks comes from Cardia. So anytime, like there was a big thing about how much marijuana impacts your lung function, that's coming from Cardia. Anything that has to do with kind of cardiovascular and pulmonary health from an HLBI comes from these studies. So 0 go into prisons and jails. 1 asks the question. And then none of them follow people into prisons and jails either. 0, okay? So then we just tried to estimate how much of the loss to follow-up in these studies of Black men might be attributable to incarceration, because we couldn't actually measure it. And it turns out it's a good bit. So ranging, from 15% the lowest, all hat's probably the lowest at 5%, to Cardia, all the way up in Black men to 25%, right? So at 25% of the estimated loss to follow-up. I'm actually not reporting this well. So red is the actual loss to follow-up, and this is how much of the loss to follow-up can be attributed to incarceration. So in this study, it looks like it's about 60% of the loss to follow-up in Black men. And so it's just a good amount. It's a significant amount in some studies. And what it speaks to me is just that, that's a picture, a sketch of one of my patients that he always loves me to share. It's Mark Baskerville. Is that for this patient, here's Mark, we just don't know much about his health. when it comes down to it, we don't know much about the health of young Black men. We don't know much about the health of men and women, but in particular men, that pass through prisons and jails. And it's a huge hole in our knowledge. And so what we've done is just within our lab is really try to change that and try to focus our questions squarely on changing the narrative around those who are incarcerated and changing the questions that are asked. And so, one of the things I'm most proud of is that we've pushed ourselves to really diversify who's here in our lab. Faculty on through students have been directly impacted. We really, this is why I know so much about Yale hiring policy and why then we work to ban the box, because I'm always that person that's trying to hire a person with a criminal record into Yale. And so I've really gotten to know the, general counsel well. And so the majority of our lab has either been incarcerated or has a family member or multiple family members that are currently incarcerated. And we're focused on preventing exposure to incarceration, mitigating the harms, and then improving health and well-being. And really, we'll only focus on interventions that look at positive assets. And mostly because those are the questions that our lab members are interested in. So, not surprisingly, they're like, we're sick of these studies. If we have to see another study that pathologizes Black people, we won't stomach it. And so, the place I'd say is for the, it's been the most growing of the work that I've done. It's what keeps us all honest, us all engaged in the more complicated questions, that enables kind of more rich dialogue about what needs to happen and how it needs to happen. It's not a space that I necessarily demur all my experience, but it is a space that where there is kind of more richness in the sorts of questions we ask and then how we approach these questions. And so, we also made a commitment about 5 years ago, just to try to get a big grant in all major causes of death. And so I'm happy to talk about these more, but, trials or epi studies going on, like Crystal, you alluded to, in these big domains. And then the last thing is that we recently got awarded a large grant looking at COVID-19 in the prisons and jails. And as I mentioned to you, it also will have an aim of it that's really focused on looking at the history of pandemics. And, I kind of switch and end with this, which is that I had the opportunity to just finish this week to co-chair a consensus report for the National Academies of Science, Engineering, and Medicine of thinking about what decarceration looks like during COVID-19 in particular. And, we're in a profound place where, again, 90 out of the 100 largest outbreaks, cluster outbreaks of COVID happened in prisons and jails up until the colleges started opening, and now that it's being taken over by colleges. But prior to that, it was in prisons and jails. And decarceration, depopulation is a big piece of a tool that can be used to mitigate COVID transmission. We've done some research that, and then there's been a few other studies, but our team has done that. And it's in that consensus report that one of the primary recommendations is focused on healthcare and healthcare delivery. That in order for us to decarcerate, in order for us to have a safe community, and I mean that in the kind of broadest, maybe criminologist sense, like a public safety, that we have to expand our notions of what safety looks like and feels like. And that has to include notions of health and well-being for people that are incarcerated, as well as the families and communities to which they return. And so I do think we're in this profound moment. I haven't been doing this for that long, but at least more than a decade, that, who was willing to have this conversation with me has changed a lot. And I'm grateful for it. It's people that are surprising, at least open to conversations about how health systems, physicians are part of, I'll stop there, a revolution, and so I just appreciate the time that y'all gave me to go through these slides and pictures, because I do think what it does do is that we've created, say like a third tier health system that's out of view, entirely out of view. It impacts so many people, their families and communities. And creates kinds, I mean, it's no wonder, you know, that of course, people are mistrustful of the health system. Look at this, you know, and so it's incumbent upon us to look internally and deal with our own stuff, which is what I feel like we have to do as physicians, but also welcome opportunities to collaborate across, especially Yale, where there's just the richness of scholars really that can kind of inform this work is mind-blowing. So thank you.
No, thank you, Emily. That was really wonderful. And I will start taking questions in the chat as well, but I do have a few, and there were some that actually came into the chat already. And so I will sort of pitch some of those as well. I know you're
I'm trying to stop my screen share.
I have a couple of questions and to get us started, but I'm hoping we could start with this idea of community-based participatory research, because it seems like it really is the center and the heart of what you're working on and what you're doing. And I'm wondering if you could talk a little bit about the principles of that, and if you could also talk a little bit about how your work and what you're doing is impacting the New Haven community.
Yeah, great. So, you know, there is a long, rich tradition of you know, I'd say like participatory scholarship, and I'll just end that sentence. Within the health sciences, it mostly emerges, when I think about it, through Barbara Israel's work in University of Michigan. And so, you know, like the expansion of it, and I would say, like, again, this is just rooting it in the US within academic structures, which is a wrong rooting. Like that's flawed, but, you know, in terms of scholarship that's looked upon, it is Barbara Israel's work, and it's within University of Michigan. And core to that, just to distill it, I would say, is this, that you will never come to solutions of health if you don't engage those that are most involved, period, end. And in doing so, there's a long range. So, you know, you'll see a lot of work, I think, in medicine. I think all of us can kind of, you know, as scholars, we'll look through the literature and be like, oh, you know, people labeling this community engaged or participatory, blah, 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 blah. So there's a scale, is how I think about it. And at its most core, you know, fundamental, if you're thinking about community-based participatory research, how it's kind of fully actualized, the question comes from the community itself, right? And it's literally, and then with the question coming from the community itself, it's in partnership, an academic community partnership, that then one is a transfer of resources. And I mean by that cash resources, one. Two, a trading of knowledge and skill. So that's more participatory, right? But again, that transfer has to come from academics to the community, right? Three, it's partnership throughout the process. It's negotiated throughout the process. It's discussed throughout the process, but it means in the first articulation of the question that comes from the community, then you find up the research question, then you figure out the methods and protocol, then you're actually implementing it, then you're analyzing it. And that's a place where there's a lot of kind of, you know, like how many communities actually have a statistician? How many, you know what I mean? Like really to get to it. So that's a place where there's deep inequities, and same with the cash. And then the last is disseminating it. But in its fullest articulation, it is full participation through the range. And I have to say, it's not easy to do. So that's the first I'm going to say. I will say, partially because the structures don't permit it. So funding structures, and also kind of deep inequities of like kind of who can manage and contractual obligations. We have tried to literally, you know, like, yeah, there's participatory budgeting kind of, I think, you know, ours is a really well-funded NIH lab, and have worked and do participatory budget. We're really transparent around it. And what that means is talking about really gross stuff, which is how much indirects Yale takes off of grants, how little communities will get, how much, you know, how to support and build that infrastructure within community organizations so that they can even take an indirect, right? And that's where it has to go, in the deepest articulation. And also that's really complicated. We had one grant that we were like, let's go 50-50. We're going to give you 2.5 million. We'll take the other 2.5 million. That means that all faculty salaries are going to be, you know, squished, but we'll do it. And there's no community organization within New Haven that could take it. It's too much work to take on. A real kind of like, grassroots organization doesn't have the accounting infrastructure to do that. And so what that requires are the infrastructures within Yale to do that. So we have a new Office of Health Equity Research with a new dean, a good friend of mine, Marcela Nunez-Smith. I'm sure you all know her. And that's finally, we're going to start trying to build the infrastructure, but it takes kind of that to be able to do it. That's one. And then the second I would say is that it's deeply enriching of the science. I can't tell you the number of times where you're like, my God, we're an idiot. We are asking all sorts of the wrong questions. Or if we'd gone for that standard validated measures, it would never have rolled out. And so it's the place where people think, oh, that's really nice. Or, oh, Emily's that left-leaning. It's what makes the science more accurate, more externally valid and internally valid. So I really push back on notions that this is some kind of like left-leaning, progressive, ways of including. That's crap. This is about the science, and it's about doing this right. And it's about shifting power. And also it's about making sure that what it is that you discover together actually is sustained beyond. And so that's in the fullest articulation. I'll just say this, Crystal, not everything should always be participatory, frankly, I think. There are places and spaces to do so. And my lab will be the first to say, it's not easy work, right? So there's stuff that we just have to get done. And it's participatory here, kind of, but we all have our different expertise and we're okay with that. So that's the second thing I'll say. And then the work that we're doing in New Haven. So clinically within the SEICHE Center, our grounding is our clinical work. Like that informs everything, because otherwise you can't keep yourself very real, even with lab members. But within, and so New Haven, we have a kind of a transitions clinic network of there's 45 programs across the country, but there's 3 sites in Connecticut. And the research that we have is mostly embedded within Connecticut. It's where we have the strongest relationships, where the assets are the greatest. And so, I'll just point out kind of the participatory project that we have going, and I'm looking at Steph, who's been involved since really early on, at least with the NIH grant. So we've had a 9-year partnership, a community academic partnership that's been focused on gun violence, and in particular thinking about community-led interventions that can mitigate and ultimately prevent the community impacts of gun violence. We were awarded NIH funding in that brief period where they had kind of an RFA focused on gun violence. And what we've been able to do is apply kind of a social network analysis. So there was a sociologist here that used to be here, Andrew Papachristos, that had a social network analysis and did that using arrest data. And we try to incorporate health system data into the social networks of gun violence. And we took his data, and what we were really interested, like I said earlier, is a positive deviance model. So, all sorts of folks are focused on those high-risk people. Who we're interested in are the people that actually are looking like they're high risk and never get shot. What are they doing right? What's helping them? The spaces in the community. There's lots of places that look like they should have had a ton of shootings, and they didn't, statistically, right? What's going on right? And so we use that social network analysis, and this is all in partnership. I'm telling you, we've gone 9 years with it. And this is the group that we're trying to give out the cash, and they couldn't do it. So they're like, oh my God, another grant. I'm like, come on, work with me. So then did qualitative interviews of either individuals or those places where things are working, or the places where nothing's happening. And Steph led a lot of that work. And then now are using both quantitative data from New Haven, the interviews, and using this thing called systems dynamic modeling. So it's kind of newer in medicine. Not a lot of folks are using, but it's a way of building a model, a computer simulated model, where you create inputs that give, where you put in local data, okay, and then can simulate and dialing up and dialing down different factors that might impact gun violence. So for instance, okay, and I'll just give you an example from our work. The process starts with something called group participatory modeling, where basically this community academic partnership, so they've now gotten all used to the terms, have to really think hard about what are the different inputs that cause gun violence in our community? And in particular, not about gun violence, but the trauma that lingers. Okay, so they create this model. And one of the big things on there, let's say, is green spaces. Okay, and that's been borne out in the literature. So of course, these folks have thought about it, but there's a good, rich empiric science behind it. And then you put it in your model. And what you can do using New Haven data is just say, like, what if we tweaked up green spaces in New Haven by 20%? What happens to rates of gun violence? What if we, and so now the community members can see this model, use it, think about the factors that they think are important to tweak up and tweak down. And part of what we're trying to identify are interventions that could be community-led entirely, not dependent on government, not dependent on police, that they could lead on their own to take action, to take hold of something that, you know, they urgently need interventions. Like every government cycle and every budget shortfall or whatever, they're done with that. And so I think we've, you know, it's complicated. You know, NIH grant cycles are 3 years or 5 years, and we're now at the place where we're coming up with the intervention. And it's both exciting, but it's also, it sometimes science is slow, gets old. Right? Like the rates of gun violence are going up, and I tire of it. But I also just remind myself that if we don't do this well and right, that I think it's going to be the same crap. Like we just don't have solutions that are actually with rigorous evidence behind it that will end up being scaled. And then we end up with more of the same, which is like if we dial down police, dial up police, community-led police. Like, and it's not to say that those solutions, I mean, that's not the conversation I entertain. That's for somebody else. Our lab is squarely focused on what works within communities and how can community leaders kind of envision their own safety and own health.
This is amazing, Emily, and I'm learning a lot. And I want to bring in a few of the other questions that I'm getting, and they range, so I'm trying to consolidate some. But there was a question about when you were talking about health as a constitutional right, and someone asked explicitly about mental health and how that factors in to folks who are incarcerated. Is mental health a part of that constitutional right, and what does it look like in the prisons?
Yeah. So I don't know the court case, but yes, it is part of that constitutional right. And then I will say, like healthcare throughout prisons and jails, there's one, a real heterogeneity to that care. And two, we just don't know, right? Like what we know is anecdotal. But what I've seen also over time, you know, I've seen really, I think like easily thousands, is that prisons and jails are in and of themselves trauma inducing. And for people that have had either go into prisons and jails with mental health disorders or have had, you know, significant traumas, and, you know, the life course of people that have been incarcerated is predominantly incredibly challenged, incredibly violent, right? And then to enter spaces that are also violent in their kind of existence, right? Yeah, I think if there are solid literature around kind of the health impacts of actually being in the carceral system, it's around mental health outcomes, and it's terrible. And so, you know, to get into the nitty gritty, I mean, what I would say though is that it is really complicated. I mean, to make, I don't know if I should go on this tangent, but to make a mental health diagnosis, and, you know, I'll just use the example of psychosis, like having kind of and, you know, I'm an internist, so I'll just say that this is not, you know, I think a psychiatrist would be like, she's not really doing it justice. But I'll just say this, is that oftentimes making the diagnoses within prisons and different diagnoses in community is just very difficult. So, you know, there's a clear-cut way of diagnosing high blood pressure, right? But there isn't you know, even though there's guidelines of like a DSM-5 criteria and we go through it, kind of the conditions of the system inside, and, you know, oftentimes people have used an illicit drug while they're outside, really, really affect those diagnoses. And so there's just so much disconnect between these health systems. A person will be on a mental health, you know, drug, treatment, engaged in care outside, and then inside not be seen in the same way. You hear what I'm saying? And vice versa. drug treated, engaged in care, come home, and they're like, we don't see. And so I think it's just like, I can't imagine, like, I would just be so frustrated because you're like, I was doing well here, and then now I've come in and there's nothing. And, or I was doing well inside, actually. And that does happen. Like I've just shared with you guys, it's counter to what we think, but some people's health, it's not to say that we should incarcerate people, but some people's health actually are managed, surprisingly, when they actually have food and a roof over their heads, so it managed better, and then come home and they're just so aggravated by not having Medicaid, not having Medicare, losing their benefits, they're homeless, they, et cetera. So that is a really complicated place, in part because of real breaks in care, in part by kind of who the providers are, how they see the person, and how they see kind of severity of illness in the certain circumstances.
Thank you. And now I had a question. It's quite very specific around someone who's been doing stuff with the Connecticut Bail Fund hotline. And one of the things that they're hearing a lot about is where in prison physicians are sometimes complicit in punishing people and withholding care and things like that. And the person is wondering, is there something that the lab or the center is going to do to address some of those issues that are happening within prisons?
Yeah. I guess what I would say is that, what we do clinically is, if we see a patient in our clinic and then we see bad care, that of course it's incumbent upon us to then talk to the provider, figure out and see what it is that we do. Within a research, that's not a place that we're actively investigating, places that, but I do think it's of critical importance. I think oversight is, as I indicated, there's none, right? There's no mandatory oversight. It blows my mind. We've just kind of absolved ourselves of responsibility. We don't want to see it. We don't want to care about it. I can't believe that, as a community, like this is something we stand for, but it is not a place of active advocacy right now for our center. The things that we're really focused on, partially because of where we think we're going to have the most leverage, and maybe this is just strategic, and also just the real deep importance of decarceration, is trying to change compassionate release, like trying to really shore up the science around it, try to change the policies. It's almost impossible to get a person to be released in this country. And, the consensus report we just did from NASAM said that, one of the things that is clear is that the jail populations are down about 22% pre-COVID and post-COVID, but the state prison population is down only 4%. And even in settings where the executive, the governor, et cetera, wanted to release, it's hard to do. Like the compassionate release policies are too specific, too discretionary, really difficult to do, to actually see it through. And so these are the things that we're working on right now.
And I have another question here. I'm going to read it, okay? It said, it's been striking to me how so much of the conservative political discussions around healthcare this year, with the conservative politicians and protesters' reactions to masks in the pandemic, and in general regarding conservative rejections of Obamacare, employs the language of force and incursion on liberty. It's been especially striking this year against the juxtaposition of incarcerated and detained individuals whose health has actually been threatened by the limitations of their liberty and mobility. What reconceptualizations of health, public health, the common good, and freedom do you see as necessary to changing public conversations and politics around health in this country?
Well, I have to say, I don't know who, and I'm going to say her, this person's name, Genia Moore, but I'm just going to say this, man, if you had an idea, you got to share it, because I think that that's literally what we spend our time thinking most about, is how can we make this an issue that is everyone's issue? And, increasingly, there's, I guess, like the ways that we've thought about it is that core to us is, as I shared, it's and I think I'm reminded daily, I mean, there's a deep urgency to this work, and it's urgent from some people more than others, but I feel like because I see patients and then my lab is always, that this is a matter of survival, right? And so trying to think about the right sorts of questions to expand this to include others, I think is important. It also, I think is, should I say this? It's not a surprise, but it also, it's not a surprise. I also, I think it's slightly loathsome too, that there's increased interest in thinking about criminal justice policies given the opioid epidemic, and a focus now that white communities, rural communities are interested. These are places of urgent intervention. It's also a place where we feel like, well, then we just have to be strategic about it. And so I think our lab really thinks hard about how it is that we can broaden the conversation, include more people. We've been increasingly, some of the research that you'll see coming out of our lab is focused on families. So we've really, there's beautiful work done by Chris Wilderman's team in Cornell, where he finally created a national estimate of how many people have a family member that's been exposed to incarceration, right? And so in this country, I don't know if y'all have seen it, but it's almost half, right? And then among Black communities, it's even higher. And so we've done a study using the data are FAMHIS. I think he's publicly shared it. So, and we've embedded in their measures of well-being. And what we found was that, pretty profound, but even if you had an extended family member that's incarcerated, a cousin, a godparent, whatever, your well-being is worse than those that have never had a person with a history of incarceration. And this well-being measure that we use translates to life expectancy. And so, I mean, I think that a lot of it is just thinking about the other stakeholders that are impacted, family members. One of our team members is now, again, within the context of COVID, starting to think about kind of correctional officers. So I recently learned that I don't know if this should be quoted because I don't know this to be a true fact, but I heard that mean life expectancy is 66. So it's crazy low. And I think it's because they work in toxic, stressful environments. The same toxicity that our patients feel, they feel too. And it's a way of also bringing in other people into the conversation. COVID is doing that for us. So it's trying to bring into the conversation other people who haven't always been in the conversation of how it is that we decarcerate. And so we're really trying to work on that. And, where we're best is both doing the research and then trying to think about more legal avenues now of trying to expand that conversation.
Emily, I was also wondering, there was another question that came up, and I didn't ask it initially, but I want to ask it because somebody asked the question, and it had to do with, I'm not sure if there was something behind the question, but they wanted to know specifically about asthma, and I'm not quite sure, but there may have been some logic in it that I just missed, because I think you were talking about a lot of the things that incarcerated people were suffering, and it may be an environmental question, but there's a question that asks how many, I'm seeing if I can find it, but how many people, are there a lot of people who are incarcerated who are suffering from asthma?
Yeah, it is a great question. And let me just see if I can just pull up. So it's a great question. So what I can say about it right off the cuff is that people that are incarcerated have higher rates of asthma compared to the general population. In fact, they have higher rates of hypertension, they have higher rates of heart disease, and then certainly of hepatitis C. So people that have been incarcerated have kind of disproportionately higher rates. And then, look at this. I'm going to just share the screen. So yeah. Here we go.
Yeah, she.
Can y'all see that?
No, I don't see. It's coming up. There we go.
There we go. So, and these are data that are taken, again, from a Bureau of Justice Statistics survey. So people that are in, I just realized I didn't never kind of define this, though this might be just real basic for you guys, but, jails and prisons are different. So jails house those people that are awaiting adjudication of crimes or serving sentences of less than a year, and then prisons house those that have been sentenced typically for sentences longer than a year. And so these data come from the Bureau of Justice Statistics. And so what you can see here, last row here, asthma is that it's 14.9% in the prison population compared to the general population at 10.2, and the jail population is 20.1 compared to 11.4. And these are data from 2011 to 2012, but are probably, they'd be the same here. It's disproportionately higher. And as is the case for many chronic conditions, cervical cancer, it goes on and on and on.
And we are running close to time, so I'm going to ask the final question. And
Yeah.
I guess the question is, and this is a big question, but I think it's an important question, and what my students are always asking me is what can we do, right? What can we do to support this work? And what's at stake if we don't in some ways, right? So in some ways, it's that kind. I feel like you've presented us with what feels like a call to action. When I see the photos and I hear how you talk about them, I'm like, okay, we've got it. We got to move on this. And so us in the community of African American studies, what can we do to support this work?
Well, it's interesting. I have to say there's, I only recently started reading history of the Freedmen's Bureau, and it's in that reading that I realized, it's a deeply challenged history, right? It was the first, if I'm understanding, national health system in our country. And was grossly underfunded and has so many deep parallels because it was essentially a second-class, healthcare system for certain sorts of people, former slaves, right? So, and it's similar. Like we've constructed a whole other operating health system that is totally out of view, that's financed by our collective dollars, that we've just thrown it away. And it has differential impacts across kind of our communities. But it's a place that I think really requires deep inquiry now. What I'm interested in seeing are kind of how doctors, health allied professionals, like how are we complicit in that, bringing out that history? Where are places, I just haven't seen. And again, I just outed myself, which is like, I've just newly started reading about the Freedmen's Bureau. So, you hear what I'm saying. It's maybe that there's a ton out there, but when we've, turned to our colleagues within history and legal scholars, and then even Miriam Rich, who's at the history of medicine within Yale, there isn't a lot as far as she can tell, and she's a scholar in mass incarceration and the intersections of health, of how physicians are complicit or haven't been, how they've been revolutionary. We need narratives that help kind of make this our own issue. And so I kind of would turn it to you, which is that I think the work that you do is illuminating. It gives us a grounding for what is possible, what had been possible, what's deeply flawed. It also makes us realize, like, in turning to a historical perspective, this stuff isn't new. I mean, it just isn't new. We just have, it's like kind of popped up again. And for me, I think, especially for generations of new med students, they think, oh my gosh, this is the first time in its own, and we just have to, I think that there are also going to be stories out there within history of solutions, of radical uprisings, of ways that health systems, more grassroots health systems have come up to fight this. And to me, those stories have to be told for us to kind of, to kind of embrace a fuller and richer and create a more honest narrative of who we are, how we are as health communities, and how we've really kind of have never cared for Black people in this country. I mean, I just invite you guys to step foot into prisons and jails. I mean, that to me is like, I feel like the first time I did it, I just couldn't turn back. And then I've been to prisons and jails all over now, the world. And so I have to say, it doesn't matter. It's just so deeply, we've created a system that really, and I don't know, I mean, the last patient I saw come home from prison was 75, spent 40 years inside. I mean, that just can't be this, 40 years inside during COVID. So I guess that's what I would say is there's a lot to be done, and I like, doctors are real pragmatic, I guess. So like, I'm like, well, there's stuff you could do now, later. But I mean, I think like for me, I mean, and then we welcome kind of, come over to our side of the campus. There's a lot going on here. And we have, I look at Crystal, but, we've developed and have growing relationships, certainly with folks on the FAS side, but, our strongest roots right now at the law school, but would love real partnerships across Yale, because I do think, like, especially just thinking about who is coming next up in your endeavors series. I mean, this is a place where I think Yale has many, many assets to offer, how we kind of reimagine and reshape conversations around what a decarcerated system looks like.
Thank you. I think that is a powerful note to end on, and an amazing invitation, particularly to our graduate students who are doing creative and imaginative work on, policing, on the environment, and how, the carceral state has impacted Black lives. And that I know that some of them after today will be drawn to the center, and I will encourage them and my colleagues to engage in a conversation with you and your work. So again, thank you for sharing this with us. We learned so much. I'm going to ask people to unmute in this moment before you go off, and we're going to do a clap that you can actually hear, right? Instead of, so if people will unmute and clap, that would be great. Thank you so much.